Thank you very much, and it's a real pleasure to be speaking here today. And the title it's long enough to be descriptive, but it really is about the nuts and bolts. It's about my experience of trying to start up a sexual health clinic in a large urban cancer center in Toronto, Canada. I have no disclosures. So the background's pretty easy. We do know that sexual health is compromised by the diagnosis and treatment of virtually all cancer types. Up to 85% of female, 95% of male oncology patients report sexual dysfunction, and the majority of those report relatively significant distress related to that. However, despite all of this, sexual health clinics are the exception in cancer centers worldwide. So it came to me, it seems that there's a real need for sexual health care in the oncology setting. I work in a big setting, so maybe I should go about opening up a sexual health clinic in my cancer center. Not so fast, right? No time, no money. And I bring this up because that's exactly what stands in front of us generally in getting these sexual health clinics up and running in an oncology setting. So let's take on no time first. And the idea is that a sexual health clinic likely saves time in clinic, meaning oncology clinics. In terms of our center, we have oncologists that will see up to 100 patients per oncologist in a clinic in a day. So oncologists do want to help their patients, but they struggle to inquire about sexual health given time pressures of their clinic. So the idea of bringing to the oncologist that we will solve that problem, we will take care of their sexual health in the sexual health clinic actually solves a problem for oncologists, and we convince them of that, and then of course we get oncologist support, and that's very important. Then we want to go within sites, and so the idea is to get site champions within each of the sites that you're working on. We did a pilot on these 7 sites, and I work very closely to try to get site champions in each of the major treatment groups that I could go to in terms of ensuring that we're trying to get the sexual health clinic embedded into patient workflow is the key. So once we have that, we have site support, that is good. The other suggestion is complement, don't compete. And the idea is that there are a lot of programs that are fabulous that are already running, complement their care, and you can support each other in kind of this inter-referral as well. So that's no time, now no money. That's a much harder one, as you can imagine. So we got to make the case, and that's not too difficult in sexual health and oncology. This is just the quality improvement statistics for Ontario, for the Ontario hospitals, and this is for EPIC, which is for prostate cancer, as an example. And the circle there are the patients that are experiencing severe problems in sexual function. So, and we can easily take a look at the literature and make the case for the prevalence of sexual dysfunction across cancers. That's easy to do. The other thing is we have oncosexology guidelines, right, that make recommendations, right? It's recommended that a discussion with a patient initiated by a member of the healthcare team. This is from Cancer Care Ontario, which is the group that oversees cancer care in Ontario, Canada. And then we have a recent guidelines, the international guidelines from sexual health care for prostate cancer patients. Specifically, this was funded by Movember. Danielle Whitman here wrote it mainly, or led the initiative. And it's a clinician initiation discussion should be conducted. So when we take a look at this, we can easily prove there's a gap in care. So then, remember, we're trying to save money, so we want to be efficient. So I think it's time that we take a look at the potential efficiencies of a virtual clinic. Luckily enough, we had some experience at the hospital I work in where we ran an in-person prostate cancer clinic that was successful, and then we actually approached by Movember to make that virtual and see whether we could put it across Canada, and we developed a share clinic. So we had both an in-person clinic and a virtual clinic, and we determined that for our in-hospital clinic, we would make a hybrid model of care by combining both the virtual and the in-person program. Don't worry about this. This is scary, I get it, but the idea is that I just want you to see that we don't want to lose personalization by going virtual, or we've lost care altogether. And so we take a look at the treatments across the top and the cancers along the left side there. And through the matrix, you can see for ovarian cancer, about 15% receive surgery only, 15% receive chemo only, and about 65% surgery and chemo. And those are two different patient populations. It's not a one-size-fits-all. This is not sexual health care for ovarian cancer patients. We have to take that into account, and we were able to identify 32 different patient streams. Then we made information. We have modules on each of the sexual health and oncology for male function, female function, physical. We also have the psychological impact. We have the impact on the partner, if they're coupled, impact on the couple, and as well some specifics like age-based interests or fertility, for example. And then we have personalized care. This is where the patient can actually choose modules to be embedded in their experience. If the patient is part of the LGBTQ2 community, then they can choose to embed that. And so again, not so much that you want to read the specifics of this, but in the actual virtual care, patient experience is personalized by cancer type, cancer treatment, biological sex, and relationship status. So this is a bladder cancer patient and a testicular cancer patient. Similar experiences, but you can see we've also personalized it to their care, which becomes very important. The other benefit, of course, is that the virtual setting, we actually have virtual sexual health counselor, a real person, and the communication can be done chat, telephone, or video conference. But it also allows for multimodal levels of communication, videos, animations, and trackers in their virtual experience. So back to saving money, resource efficiency, staffing, what do we do there? And what we do is we have very efficient use of our sexual medicine physicians. It's quite an easy consult for them because remember, they're in the virtual program and they have a counselor. So there's a lot of, the patients are well educated when they come in, and so it can be very focused assessment. And also, patients are always seen in the in-person clinic by a sexual health counselor first for a consult, and that also streamlines the care. As well in the virtual sexual health counselors, it's chat-based, and a single counselor can manage hundreds of patients because the system is already supporting them in education, and then the chat-based discussions are quite finite. Then remember, we all work in a hospital, and we have to get some feedback to the hospital. So, you know, a priori, when you're setting up your clinic, make sure that you're able to collect data. And we have consent for collecting data right in the virtual care program, so we don't have to necessarily even do it in the in-person clinic. This allows us to do quality improvement and report back to the hospital, but we're a teaching hospital too, so we can expand and present in the research literature. And in fact, we even have a methodologist, a statistician, and knowledge translation specialist in our clinic. So, all right, perfect. Ready to open up that clinic. Well, actually, not so fast, right? The idea is implementation. If you build it, will they come? And again, it's the importance of knowledge translation and implementation science can't be underestimated. The idea being that oncology settings knowing that most research findings, even positive full-scale studies, do not result in practice change or take years to do so. This is even more so true in sexual health care, given stigma, embarrassment, and limiting training. The statement of healthcare interventions that are effective but not implemented are no more beneficial than those that are implemented but ineffective. So we didn't just take from the literature, we actually went and interviewed stakeholders. Remember, with the goal of ensuring that sexual health is embedded in patient flow across each of the cancer sites. So we interviewed stakeholders, and we found really 3 organizing domains and 10 sub-themes. And when we take a look at those, there was a recognized need by everybody involved. It's quite obvious to physicians and clinicians in the hospital. There was obviously concern about confinements of care, and then there was key factors of implementation. And if we take a look at the hybrid clinic that I just talked about, we are prioritizing it. We are providing personalized care. We're overcoming mutual silence and avoidance. We are managing that lack of time, as I said. We have a unique space. We have engagement flexibility. But where we hadn't really put enough effort in is normalizing patient inquiry and normalizing provider inquiry. So we went on an effort to do that as we were launching this. This is a pre-implementation efforts, and we normalized that patient inquiry by being on websites. I mean, you can't go into the hospital without learning about the sexual health clinic, which is wonderful. The other is that I went on a road show, basically, and I went to rounds, I don't know how many times over a 12-month period, just to keep telling everybody over and over again that we were opening up this clinic and we were there to service their patients. And then we normalized provider inquiry. We did practitioner training as well. So then the question is, if they bill it, will they come? Well, in fact, they will come. So just looking at 2023, in our first year of doing this, we had 381 referrals to the clinic. Of those referrals, we had over 80% showed intention to attend. So the referrals came in, they were contacted, and showed intention to attend. It is prostate cancer heavy, as you can see, but we were able to reach 24 different cancer types as we continue to get into the actual clinic workflow of the other cancer sites. And then when we look at the intention, the actual, if we contact them and they intend to come to the clinic, they generally do come to the clinic at a rate of 90%. The other good thing is we were able to measure the engagement. Remember, of course, they're engaged in the in-person clinic. How successful was our virtual platform? And it was very successful, the idea being that about 1,867 messages were received and provided to by the patient and the counselor. And as well, we call it clinic visit slides. A patient going onto the virtual clinic, on average, saw 247 slides of information over the year period. So here's where we get to the kind of the basics of it here, and this is our budget. And so in staffing, we have a clinic manager, and we have a clinic coordinator, and a sexual health counselors. And then we have the cost for the virtual platform. We included training, where we paid for some training of some of the sexual health counselors. Then we took a look at publications and printing and the like. And the cost is about $100,000 to run that clinic. And we intend to expand, so that'll go up a little bit. But the idea is that it's pretty darn affordable. And then for all of you here, it's actually really affordable if I was running out of the States. I'll finish my talk there. I'm a little ahead, which is good. But the idea being is that I really wanted to kind of not so much talk about a sexual health clinic globally, but what's it like to actually boots on the ground, get something embedded in a program.